Welcome to this educational video produced by Wessex local medical committees. This is aimed at clinicians working in primary care, and this video will last about 10 minutes. This is the first quick update that we've produced and focuses on cancer. If you have any comments or feedback, please let us know. This update is focused on how survival rates for cancer are improving and what can be done to further improve outcomes. Better outcomes will result from better prevention, earlier diagnosis, as well as improved treatments. This is an important area for general practice, not only because of the large number of patients who develop cancer, but also because of the cancer initiatives in the NHS long-term plan and the service specifications for primary care networks focused on the early detection of cancer. Cancer causes more than 25% of deaths in the UK, and about 50% of people will develop cancer at some time during their life. The survival rates for cancers are improving all the time, and have in fact doubled since 1970. We know that approximately 350,000 people will develop cancer every year, and some of the most common cancers are breast, prostate, lung, and bowel. These account for more than half of all the new presentations of cancer. About 42,000 people a year are diagnosed with breast cancer in the UK, of which 99% are female. 80% of the breast cancers occur in women over the age of 50, and the survival rate for breast cancer has doubled in the last 40 years. Breast cancer is the fourth most common cause of cancer deaths in the UK, and the most common cause of cancer deaths in women aged less than 50. Prostate cancer is the most common cancer in men, and about 1 in 8 men will get prostate cancer in their lifetime. Prostate cancer mainly affects men over the age of 50, and your risk increases with age. The risk is even higher in certain ethnic groups and men with a family history of prostate cancer. You're more than 2.5 times more likely to develop prostate cancer if you have a brother or father who has had prostate cancer, compared to a man who has no relatives with prostate cancer. Lung cancer accounts for about 13% of all cancers and will occur in 1 in 13 men and 1 in 15 women. It is estimated that 80% of lung cancers are preventable, and that 70% of lung cancers are directly caused by smoking, and about 5% are caused by ionizing radiation. Over the last decade, lung cancer rates in male have decreased by about 10%, but the rates in females have in fact increased by 17%, and this is thought to be directly related to smoking trends. 1 in 15 men and 1 in 18 women will be diagnosed with bowel cancer during their lifetime, and most bowel cancers occur in the rectum. It is estimated that about 50% of bowel cancers are preventable. About 4 in 10 cancers can be prevented. This is by taking lifestyle actions such as stopping smoking, keeping a healthy weight, eating a diet with less processed food and one that is high in fibre, being safe in the sun, reducing the risk of certain infections such as HPV, drinking less alcohol, and generally being more active. And finally, reducing the use of HRT to the minimum that is necessary. When one of our patients develops cancer, we will look back at previous consultations to see if we could have made a diagnosis earlier. Many will discuss such cases at a significant event meeting with colleagues and see what lessons can be learned. I'm sure, like me, you get fed up with headlines in the newspaper, such as the one in The Guardian in April 2017, which stated that cancer symptoms were often missed by GPs. This was a report of a study analysing over 4,500 people who were diagnosed in A&E with cancer. But this was looking back to a study done in 2010, which suggested that over 40% of people had seen their GP 3 or more times before attending accident and emergency. This is in fact a gross misrepresentation of the challenges we face in general practice, both in terms of making an initial diagnosis and the complexities of patients with multiple symptoms and symptoms that they present with that are not always typical of cancer. As I stated previously, there are about 350,000 people diagnosed in the UK with cancer every year, and more than 165,000 cancer deaths. And cancer accounts for about 28% of all deaths in the UK. It is therefore not surprising that cancer is one of the major areas of focus within NHS England's long-term plan. We know that the one-year survival rate has increased from 62% in 2001 to 73% in 2016. The 5-year survival rate for cancer in the UK is currently about 60%. The NHS long-term plan has ambitions that by 2028, 75% of cancers will be diagnosed at stage 1 and 2, and that 55,000 people per year will survive more than 5 years after diagnosis. The aim is to improve survival to compete with the best in Europe. More about this later. The 5 most common cancers are breast cancer, where 90% of people are diagnosed at stage 1 or 2, prostate cancer, where only 55% are diagnosed at stage 1 or 2, lung cancer, which generally has a poor outcome because more are diagnosed in late stages and only 30% are diagnosed at stage 1 or 2, colorectal cancer, where 45% are diagnosed at stage 1 or 2, and melanomas, where 92% are diagnosed at stage 1 or 2. The 5 most common cancers with the worst survival rate are pancreatic, esophageal, non-Hodgkin's lymphoma, lung, and ovary. And often these present late because their symptoms are not typical or present early in the disease process. Clearly, the single factor that would reduce the incidence of lung cancer would be if more people were non-smokers and those who currently smoke stop. Around £70 million has been invested in 10 national pilots to check those most at risk of lung cancer and inviting them in for an MOT for their lungs and an on-the-spot low-radiation CT scan. These are delivered through mobile clinics that will be delivered closer to where people live. One of these pilots will start in Southampton in 2020. These are built on studies that were done in Manchester and other areas of the country. Prior to the study, 18% of lung cancers were diagnosed at stage 1 and 48% at stage 4. After the study, 68% of lung cancers were diagnosed at stage 1 and 11% were at stage 4. The scheme means that people aged 55 to 74 who've been identified as being at increased risk of lung cancer, i.e. smokers and ex-smokers, will be invited for a lung health check and be offered a chest scan if appropriate. The risk of cancer increases with age. In 100 people who develop cancer, 1 will be aged less than 25, 10 will be aged between 25 and 49, and 89 will be aged 50 or more. Incident rates are strongly related to age for all cancers combined, with the highest incidence rates being in older people. Age-specific incident rates rise steeply from around the age of 55 to 59. The highest rates are in the 85 to 89-year-old groups for both females and males. Incident rates are slightly higher in females than in males in the younger age group, and significantly lower in females than males in the older age group. Deprivation has a significant impact on cancer. There are around 22,000 extra cancer cases per year in England because of the incident rates are higher in more deprived groups for most cancers. However, there are around 7,000 fewer cases because the incident rates are higher in the less deprived groups for some cancers, which include breast, prostate, and melanomas. So there is a net excess of around 15,000 cases per year in the socially deprived areas of the country. Lung cancer has by far the largest number of excess deaths caused by this socio-economic variation. If we're going to improve the survival rate for people with cancer, the National Screening Programme will play an important role in this. There are currently screening programs for cervical cancer, breast cancer, and colorectal cancer. Breast screening is expected to save 1 life for every 200 people screened. This is approximately 1,300 women per year. Women are offered breast screening every 3 years between the ages of 50 and 70, and currently about 70% of women attend screening, but this does vary significantly from area to area. Regular bowel screening is expected to reduce deaths from colorectal cancer by about 16%, but again, the uptake varies significantly from area to area. About 3,000 women are diagnosed with cervical cancer per year, and this is the most common cancer in women aged under 35. Almost all of these patients have HPV, so with the introduction of vaccination for both girls and boys, this should have a major impact on the incidence of cervical cancer. The uptake of cervical screening has fallen in recent years to below 80%, and in some areas the uptake is significantly less than 80%, particularly in areas of deprivation. Cervical cancer is seen as a totally preventable cancer. If we're going to improve survival rates, we need to do a number of things. We've already mentioned prevention and the role of lifestyle factors. Screening will help detect cancer at an early stage and improve survival rates. Clearly more can and should be done to increase the uptake for cervical, bowel and breast screening, especially in the hard-to-reach groups. The introduction of lung screening, with the reduction in the number of people smoking, will reduce the number of people with lung cancer and improve survival rates for those who develop it. We also need better and faster access to diagnostics to prevent delays in diagnosis. The use of the 2-week or fast-track pathways have made a significant impact on outcomes and have resulted in patients having quicker access to diagnostic tests and specialist care. But there remain a number of patients who are let down because they don't fit neatly into any of the pathways that currently exist. There are symptoms such as unexplained weight loss, a high platelet count, abdominal discomfort, or simply that the clinician has a gut feeling that there may be a cancer as the cause of undifferentiated symptoms. We're hoping to address this with the introduction of a rapid diagnostic service early next year that will result in a new pathway where clinicians can refer those patients where they suspect cancer, but the patients don't fit into the existing 2-week cancer pathways. Better treatments, including the new area of genomics, will also play a role in improving survival rates. GPs look at significant events and learn from cancer audits that are undertaken in their own practice and across larger geographical areas. Therefore, continuing education and training plays an important part in ensuring general practice is up to date with all relevant developments. As age is one of the most important factors in developing cancer, we need to be aware that although age should not be a barrier to treatment, a person's general state of health and life expectancy will have a significant influence on the treatments that are available and the potential survival rates for specific cancers. This quick 10-minute update relating to cancer has been produced by Wessex local medical committees. I hope that you found it useful and informative, and if you have any feedback, please send that to the LMC. We'd be interested to hear your thoughts and views. Thank you.